Immune thrombocytopenia (ITP) is an autoimmune disease. Look at this picture, shows that the disease mechanism, signs and symptoms, and blood test for diagnosis. Detail going on. Introduction. Immune thrombocytopenia is an autoimmune disorder characterized by a low platelet count, which can lead to increased bleeding and bruising. It occurs when the immune system mistakenly attacks and destroys platelets, essential components of blood clotting. The term immune thrombocytopenia (ITP) originates from Latin and Greek roots. Immune relates to the immune system, while thrombocytes from Greek thrombos meaning clot and kytos meaning cell refers to platelets and penia from Greek pene signifies deficiency. Initially called idiopathic thrombocytopenia purpura, the name evolved to reflects the autoimmune mechanism underlying the platelet destruction rather than an unknown cause. A definition. ITP is defined as a hematological disorder where the platelet count falls between 100,000 NuL in the absence of other underlying causes or conditions. The destruction of platelets is primarily mediated by autoantibodies. Types 1. Primary ITP, idiopathic without an identifiable cause. 2. Secondary ITP, associated with other conditions such as infections, HIV, H. pylori, autoimmune diseases, or drug induced reactions. 3. Acute ITP typically occurs in children and resolves within 6 months. 4. Chronic ITP persists from more than 6 months, often affecting adults. Causes 1. Autoimmune response leading to platelet destruction. 2. Infections, example viral infections like Epstein-Barr virus or H. pylori. 3. Medications, example quinine, heparin, or certain antibiotics. 4. Associated autoimmune disorders such as systemic lupus, erythematose. 5. Genetic predisposition. Risk factors. 1. Age, common in children and adults over 60. 2. Gender, more prevalent in women. 3. Recent infections or vaccinations. 4. Family history of autoimmune disease. 5. Use of specific drugs known to trigger immune response. Complications. 1. Severe bleeding, internal or external. 2. Intracranial hemorrhage in rare cases. 3. Fatigue due to chronic low platelet counts. 4. Potential adverse effects from treatment, example immunosuppression. 5. Psychological impact due to chronic illness. Pathophysiology. Immune thrombocytopenia is an autoimmune disorder characterized by immune mediated destruction of platelets and reduced platelet production, resulting in thrombocytopenia, low platelet count. Below is step by step explanation of its pathophysiology. 1. Initiation of autoimmune response. Trigger immune dysregulation. 2. Formation of antiplatelet autoantibodies. Glycoprotein most common. These autoantibodies bind to platelets and megakaryocytes in the bone marrow. 3. Platelet destruction. Fc receptor mediated clearance. Complement activation. 4. Megakaryocyte suppression. 5. T cell mediated platelet damage. 6. Thrombocytopenia. 7. Clinical manifestations. Bleeding, compensatory mechanisms. 8. Chronicity and relapse. In chronic ITP, persistent immune dysregulation maintains platelet destruction. T. Regulatory cell dysfunction and persistent antigenetic stimulation contribute to relapse. This pathophysiology highlights the complex interplay between autoantibodies, T cells, and cytokine mediated mechanisms that culminate in thrombocytopenia. Understanding these steps guides therapeutic strategies such as corticosteroids, immunosuppressive agents, or splenectomy. Signs and symptoms: 1. Petechiae, small red or purple spots on the skin. 2. Ecchymosis, bruising without apparent trauma. 3. Gingival bleeding or nosebleeds. 4. Prolonged bleeding from guts. 5. Heavy menstrual bleeding. 6. Fatigue or weakness. 7. In rare cases, life threatening hemorrhages. A diagnosis: 1. Clinical assessment. Detailed history, recent infections, medications, family history. Physical examination to check for bleeding and bruising. 2. Laboratory tests. Complete blood count, CBC, low platelet count, peripheral blood smear. Rule out other causes of thrombocytopenia. Bone marrow biopsy in unclear cases, normal or increased megakaryocytes. 3. Additional tests. Antibody tests for platelet specific autoantibodies. Test for secondary causes. Example: H. pylori, viral markers. Nursing diagnosis: 1. Risk for bleeding related to low platelet count. 2. Fatigue related to chronic disease process. 3. Anxiety related to fear of complications or treatments. 4. Knowledge deficit regarding conditions and management. 5. Impaired skin integrity related to petechia and ecchymosis. Management. Medical management. 1. Pharmacological treatment. Corticosteroids to suppress immune activity. Intravenous immunoglobulin for rapid platelet increase. Thrombocytopenia receptor agnosis to stimulate protein production. Immunosuppressants in refractory cases to surgical treatment. Splenectomy for chronic and refractory ITP. 3. Emergent treatment. Platelet transfusion in life-threatening bleeding. In nursing management, 1. Monitor for signs of bleeding and bruising To educate the patients about avoiding activities that increase bleeding risk. 3. Encourage adherence to prescribed medications. 4. Provide psychological support to alleviate anxiety. 5. Collaborate with healthcare providers for regular monitoring and follow ups. Treatment options: 1. First line treatments: corticosteroids, IVIG, and anti-D immunoglobulin. 2. Second line treatments: thrombopoietin receptor agonists, immunosuppressants, splenectomy. 3. Supportive treatments: platelet transfusion for emergencies, management of associated conditions, example infections. Psychosocial medicine: 1. Counseling: address emotional and psychological concerns. 2. Support groups: connect patients with others facing similar challenges. 3. Education: provide comprehensive knowledge about the disease and management. 4. Stress management: techniques such as mindfulness and relaxation exercises. 5. Family involvement: engage family members in care, planning, and emotional support. Prevention: 1. Avoid unnecessary medications known to induce thrombocytopenia. 2. Timely vaccination to prevent infections. 3. Early treatment of underlying conditions. 4. Regular monitoring in individuals with autoimmune tendencies. 5. Adopting a healthy lifestyle to maintain immune balance. In conclusion, immune thrombocytopenia is a manageable condition with timely diagnosis and appropriate interventions. By understanding its pathophysiology, symptoms, and treatment modalities, patients can achieve better outcomes and maintain quality of life. Comprehensive medical and nursing care, along with psychosocial support, plays a pivotal role in effective disease management. Thank you. Have a nice day.